So today we are here to discuss about PCOS and prediabetes. See, first of all, I would like to define both this condition. PCOS is a hormonal disturbance. It's a metabolic condition where what happens that your ovaries has got multiple kinds of small follicles or cysts, you can say, which are unable to form a dominant follicle, and they are not able to this without forming any dominant follicle, they are not able to have a proper ovulation, so because of which you suffer from irregular cycles. So why is this happening? This is because of the increase in the androgen levels. See, our ovaries has got a lining which is called as thicker cell lining. That lining is responsible for making androgens. So women's whose androgen who suffer who has got high androgen levels, because of this increase in the androgen production from the ovaries itself, because of which there is abnormality in the ovulation. The cycles are not, these androgens will interfere with the ovulation, and the follicles will not be able to form a dominant follicle, which helps in ovulation. So that's why you will have the irregularity in the cycles. And along with that, as your androgen levels are high, that will leads to increase in the male hair growth pattern. You might see that there is a coarse hair growth over the upper lip, chin, over the breast areas, upper abdomen, lower abdomen, arms and thighs. So abnormal hair growth can happen. And the third thing is, like, radiologically you can find that there is a multiple cyst in the ovaries. So basically, clinically, you will find that your cycles are irregular. You are missing your periods. You will have the cycle duration will be less than 7 to 8 per year. Or sometimes what happens when it can in few patients there can be a frequent, either there can be more, there can be increase in the frequency of the cycles also. So usually we get oligomenorrhea, that is less cycles, but sometimes you can get increase in the cycle frequency also, because of the increase in the estrogen load. You are not ovulating, but because of the increase in the endometrial lining, that endometrial shedding can happen intermittently. So intermittent bleeding, intermittent spotting can also be seen. And the patho, why is this happening? It's like it's a vicious cycle. Because of the increased androgen levels, there is increase in the insulin production, and this insulin production can further leads to increase in the androgen level. So this cycles keep on going. It's an ongoing vicious cycle, and because of which there is more in the there is higher insulin resistance, and thus it leads to further increase in the androgen levels. And women with PCOS has been found that they are obese and they have got insulin resistance. That means that their insulin is not able to act properly, and it's not able to utilize the glucose. Whatever you are eating, whatever the glucose rise is happening because of the food, it's not been able to utilize because of the insulin resistance. Insulin is not able to act at its receptor. So you have got hyperglycemia. There is always rise in the glucose values. And because in order to compensate, or in order to balance this glucose, your pancreas will try to produce more insulin. So on one hand, your already insulin level is high, and because of the glucose, stimulus is always there, and so more and more insulin production is ongoing from the pancreas level. So what happens, because of this higher insulin level, this will act at the ovaries, and it will again leads to rise in the androgen level. So basically, it's a these two things are interlinked: higher androgen levels, higher insulin, and higher glucose reading. So this is how the women with PCOS suffers from pre-diabetes, or diabetes, we can say, from metabolic abnormalities. So it has been seen that the incidence wise, if we discuss, then 1 in 10 women suffers from PCOS, and out of 40 to 50% of women with PCOS, they suffers from pre-diabetes, or you can say that there is early borderline diabetes value. And out of this 50% pre-diabetic patients, they can land up with frank diabetes. Up to 10% of up to 10% of this pre-diabetic patients can land up to uh, frank diabetes. Okay. So, and the risk factors for developing this pre-diabetes or frank diabetes is if you have got family history of diabetes, if you have got history of gestational diabetes, and if you are obese. So these are the risk factors because of which you can develop diabetes at later age, like by the age of 40. Okay. So the next thing is like how to screen and how to diagnose this pre-diabetes or diabetes condition. So all PCOS patients should be screened for 2-hour oral glucose tolerance test. That is that they are asked to take 75-gram glucose in the empty stomach, and then after 2 hours they have to give sample for their glucose. Okay, so this is basically is the standard screening test, and through which we can detect pre-diabetes or frank diabetes in PCOS patient. See, you know that fasting in all diabetic patients we ask for fasting blood sugar. Yes, but in PCOS patient, what happens because of the insulin resistance and their OGTT value, this test is called OGTT, that is oral glucose tolerance test. It has been seen that OGTT gets more deranged compared to the fasting. Like you can have your normal fasting blood sugar, but your OGTT will be impaired. So for screening, we asked our patient to go for OGTT, as well as they can also get their HbA1c done. That is the average glucose, 3-month average glucose test. Okay. So what is the range? The range is fasting. If the range for pre-diabetes is fasting blood glucose of value 100 to 126 is labeled as pre-diabetes, and more than anything beyond 126 fasting blood sugar is frank diabetes. Similarly, for OGTT, up to from 140 to 180 reading, it's impaired, or you can say in the pre-diabetic or in the borderline diabetes. And once this OGTT value goes beyond 200, it is labeled as frank diabetes. And for the HbA1c, the average 3-month average which we test, the cutoff is 5.7 to 6.4 is in the pre-diabetic range. And if it is goes beyond 6.5 or more than or equals to 6.5, then it is labeled as frank type 2 diabetes mellitus. Okay. So so to summarize here, we can say that fasting blood glucose may underestimate the prevalence of diabetes when compared with the oral glucose tolerance test. So now next thing is like how to manage this condition. Like once you have come to know that you have got PCOS as well as pre-diabetes, so how to prevent this condition? So to prevent pre-diabetes developing into type 2 diabetes, for that you have to the only management is the lifestyle management. And in some cases, if there is extreme obesity, if the BMI is extremely high, in those cases, more than 35 BMI with pre-diabetes, in those cases, we can add metformin along with a lifestyle modification. So this lifestyle modification, what does it mean? It means behavioral modification, taking a healthy diet, doing exercise regularly. And it has been seen that if a patient continues this lifestyle modification for 1 year, then it can prevent developing type 2 diabetes in the next up to 7 years. So even if a 1% weight loss, if you do, then it can lead to 16% reduction in the development of type 2 diabetes. So you can see how major is the benefit of doing following a healthy lifestyle. So for healthy lifestyle, you have to follow a healthy diet, which could be, for which you have to consult your dietitian, and accordingly your dietitian or nutritionist will chalk out a plan, and then you have to follow that strictly. Okay. And coming to the exercise pattern, you have to do 30 minutes of any cardiac exercise, which can be brisk walking or any aerobic exercise for around 5 days in a week. Along with that, you have to do some freehand exercises. What happens when you do exercise, whatever the glucose high glucose levels are there in the blood, it gets uptake in the large muscles. So your muscles utilize this glucose, and thus it also reduces the insulin resistance. And if you decrease the insulin resistance, if you control this metabolic parameters, and with healthy lifestyle, you can also reduce your PCOS symptoms also. It has seen that weight reduction following a healthy lifestyle will also helps in decreasing your androgen levels. And once your androgen levels comes down, then your cycles will regularize. We treat this symptoms of PCOS with hormone pills, but along with that we have to follow a strict lifestyle management. Okay. So if we come to the management of PCOS, we have got like it depends upon the symptoms, what are the symptoms and what is the patient concern. Like if a patient comes with irregularity in the cycle with high androgen levels, for those cases we advise them to go for lifestyle modification, weight reduction, exercise. Along with that, we start them with oral contraceptive pills, that is a hormonal pills, which will help in reducing the androgen levels, and then it will help also regularize the cycle also. For patients who comes for the hirsutism, or whose main concern is the excess hair growth, for them we have to go for the local treatment also, local treatment as well as for the contraceptive pills. because again we need to target the androgen levels. So we continue with this contraceptive pills for a period for around 6 months, and even after that, the hair growth, if it doesn't reduce, then we start on other anti-androgen therapy, which we other therapies are also there for this hair reduction in the hair growth. Okay, but the main crux is for all PCOS patients, they have to do exercise, they have to follow a healthy diet pattern, they have to regularly check their metabolic parameters, that is their fasting blood glucose, HbA1c, LFT, lipid profile, and they have to keep a record of their cycles, and and they have to always go for a target weight reduction. Even 5 to 7% of weight reduction will help in controlling or reducing their symptoms. So, anything else you want to know? Like, this is like the basic concept about PCOS, which I'm discussing. If there are any doubts, I would like to have an interactive session. If you have any doubts, then I would be happy to answer that.
Doctor, you related pre-diabetes to obesity a lot. So I just wanted to know, is it relevant only for people who are overweight and obese, and not on anyone who is otherwise, anyone underweight or regular weight, lean PCOS, for
See,
example?
no, for all PCOS patients, it has been seen that all PCOS patients, even if they are lean, they have got insulin resistance. Their visceral adiposity levels is high. So for all PCOS patients, we should go for pre-diabetes screening, that is OGTT, as I discussed, and as well as HbA1c, irrespective of their BMI or weight. Okay, and for general population, it's like it depends upon the risk factors. For people who are more than 45 year of age, for them we recommend routine screening every yearly, and if the readings are found to be normal without any other risk factors, then we ask them to follow a healthy lifestyle. Along with that, we keep on the screening every 3 yearly if the baseline readings are normal. Now, coming to the patients who have got risk factors, like who has got family history of diabetes, who are obese, who have got symptoms of PCOS, who has got history of GDM, who has got hypertension, obstructive sleep apnea, cardiovascular diseases. So these are the risk factors. So for those patients, even after, for those patients after 30 or 35 years of age, we ask them to go for this pre-diabetes or this diabetes workup screening. And if at baseline, if it is found to be normal, then again every 3 year early they have to go for the screening test.
Okay, great. Also, I want to know, you said only when a person is, BMI is over 35 and they have diabetes, then metformin is recommended. That was one of the sentences you said. So that caught my attention because
Pardon, I can't hear you. Your voice is breaking. Can you please repeat the question?
yeah, hello, is it better now?
Yeah, yeah. Some disturbance was going on. Yeah.
Right. You told that metformin is usually given and the BMI is as high as 35 and they have a pre-diabetes, condition, right? So my question is, say if it's someone who has the 26, 27 BMI, that is borderline overweight, right? And they show pre-diabetes things, even then is metformin recommended? And second thing is, when you have metformin, do you kind of become resistant to it? Like after a point, does it stop having the same effect it had on day one?
See, for it's I told that pre-diabetic patients with BMI of more than 35, for them we should give metformin without having PCOS. But for patients who are having PCOS with pre-diabetes, irrespective of their BMI, we should give metformin for PCOS patients. Okay, because PCOS patients has got insulin resistance, and metformin reduces the insulin resistance. And irrespective of the BMI, if they have got impaired glucose tolerance, or if their glucose values are in the pre-diabetic range, we should treat them with metformin because it has got added benefits. It reduces the insulin resistance. It will correct the hyperglycemia. It will prevent the progression from pre-diabetes to type 2 diabetes also. Okay, and coming to your second question, see, yes, metformin, it has been seen that metformin helps in weight reduction also, but that weight reduction is not so good. Like, it leads to hardly 1 to 2 kgs of weight reduction initially, but in the long run it doesn't lead to weight reduction. So in terms of weight reduction, yes, definitely metformin initially will help in weight reduction, but further won't help in further continuation won't help in weight loss. But keeping in mind that we are not giving metformin for weight reduction, we are giving to reduce the insulin resistance as well as to correct the hyperglycemia. For that, whatever the dose is there, we start usually with 500 milligram once daily, and then we can titrate it up to 200 milligram per day. So that is what is the maximum dose we use. So, but depending upon the glycemic status, we decide how to titrate the dose.
Right, got it. Thank you. Hi, guys. If you have any questions, please feel free to unmute yourself and ask as well.
Hi, doctor. I have a question. So there are two things now, metformin and inositol. So which one do you suggest? Like one of my doctor had suggested inositol, and when I went for the second opinion, they had suggested metformin. So
Hello. Yeah, I know this is a very common scenario. We face it in very frequently in our day-to-day practice. See, it depends upon, see, for myo-inositol, I would say that we still don't have evidences that it provides any benefit. So as an endocrinologist, I won't suggest you or any of my, and I don't suggest any of my patient to continue with the myo-inositol to reduce the insulin resistance. Okay. Now coming for with the metformin, like as I said, all PCOS patients, they should go for pre-diabetes screening. And if that screening comes to be positive, or if you are found to have dysglycemia, or if your glucose values are in the pre-diabetic range, for those patients only we recommend metformin. Still, we don't have any evidences that metformin helps in pregnancy or it will help in reducing the PCOS symptoms in a normoglycemic patient. Okay. So if your glucose values are de-raised, definitely we should start metformin therapy even in the pre-diabetic stage. But if your glucose values are in the normal range, just to reduce your PCOS symptoms, we do not recommend metformin therapy. And for myo-inositol, I repeat that we don't have any evidences that it helps in improving the PCOS symptoms or it reduces the insulin resistance. And even if we talk in terms of pregnancy, if the PCOS patient wants to become pregnant and they are like planning for infertility treatment or fertility or if they are planning for ovulation induction, still for those cases, if they have got only dysglycemia, then only metformin, we continue with the metformin. If they do not have any like their glucose values are in the normal range, so we do not start metformin to help in the fertility treatment. Okay. And even the pregnancy, if the PCOS patients conceive, even in the pregnancy, if the glucose values are normal, then we do not initiate metformin just to control the PCOS thing. Okay. Even in the pregnancy, we do not recommend routine metformin prescription in a known PCOS patient.
Okay. Thank you so much.
I have a question. Do extreme stress levels have any impact on elevated glucose levels? Because I was tested 4 times. It's like half an hour, half an hour, half an hour. Yeah, so I was crying and all that. I hated the entire thing. What happened was I was given a lot of glucose. It was too sweet. They asked me not to puke also. The first value after half an hour was slightly elevated. After the 2 hours, it came down to normal. So how do I take this? Yeah.
See, yes, stress can lead to hyperglycemia, but that hyperglycemia is transient, and usually in a without any other sick condition, like if you have got renal failure or heart failure or some other comorbid condition or any infection, then only the stress hyperglycemia precipitates. In your condition, as you are saying that half an hour value was high, it is expected. Like your insulin levels, your glucose utilization will take some time. That's why we ask the patient to give their blood sample after 2 hours and not in every half an hour. I don't know why you were prescribed to give your samples every half an hour. Usually after the glucose intake, directly at 2 hours we check for the values, not at every interval. For pregnancy we check for 1 hour as well as for 2 hours, but for routine cases only 2 hour glucose value is recommended. And that's what we decide, and that value will help us to decide whether you are having pre-diabetes or diabetes or not. So if your 2 hour PP value was normal after oral glucose, so I would say that if it was less than 140, so it's normal. Between 140 to 180, it's in the impaired glucose range, that is in the borderline diabetes in layman term. And if it is more than 200, then definitely type 2 diabetes.
It was
Type
actually exactly 140. So she prescribed me so much metformin, and LDL
Yeah,
was slightly high, and she prescribed me statins and all that. It was very
yeah.
scary to see.
No,
Yeah.
yeah. If once the value comes between 140 to 180, we should start metformin if you have PCOS.
Okay.
So,
Okay.
and statin and all, all are the metabolic parameters which we test, even LFT, lipid profile, your thyroid functions, prolactin, all these are the tests which we do for before starting PCOS treatment. Actually, PCOS is a diagnosis of exclusion, basically. So before the stamping patient as a PCOS, we need to rule out many other hormonal conditions. Like you have to check your thyroid levels, you have to check your prolactin levels, you have to check your other androgen levels, from where the androgen levels can increase. So basically, after ruling out other like disorders, then only we can say that yes, you have PCOS. So basically, it's a constellation of symptoms and this biochemistry.
Okay. Thank
Is
you.
it next? Yeah, thank you. Next question is from Harshita. She's asking, is there any effect of metformin with regards to fatty liver? See, again here, metformin doesn't leads to fatty liver. First of all, second, it doesn't leads to reduction in the fatty liver. Only if you have borderline, if you are having hyperglycemia, or if your glucose values are deranged, to manage your glycemic status, we recommend metformin and not for fatty liver. Yeah. And if you have got acute your liver enzymes are raised like more than 5 times in the background of fatty liver, so for those cases we do not recommend metformin till your liver enzymes normalize.
There is another question. Do we need to take glycomet tablet for a long time to balance the glucose levels, or it can be stopped once the glucose levels are in normal level? Does metformin help with weight loss? Two questions.
Actually, we have already discussed this. For if your glucose values are high, so you have to continue with the metformin therapy along with the lifestyle modification. Then, and you have to follow with your HbA1c. And after for 1 year of treatment, if your A1C comes down to less than 5, so you can discuss with your doctor of reducing the metformin dose. And even with the lesser dose of metformin, like around 500 milligram per day, if your glucose values are maintaining, your A1C is maintaining in the non-diabetic or in the non-diabetic range, like less than 5.7. So for those cases, if they're motivated enough to continue with the lifestyle modification, we can give a trial therapy of stopping the metformin. Very importantly, once you stop your medication, you have to be in the follow-up with your doctor to see whether after stopping medicine, is there any rise in the glucose values or not. So actually, it all depends upon the titration, the follow-up. So for 1 year, we usually recommend, and then we follow up, and then we decide what to do. And yes, as I said, metformin helps in weight loss. Initially, 1 to 2 kgs weight loss can happen with metformin, but in the long run, it is not an anti-obesity medication. It doesn't lead to weight reduction in the long run. So whatever weight reduction we achieve, it's in the initial phase of the therapy. So for the weight reduction, I think we can do another webinar to discuss the therapies and this thing, how to have like medications for the weight reduction and lifestyle modification.
There's one more question. Can you please elaborate on spironolactone, as I was suggested that by my doctor?
Yes. Hello, Chan. Yes, spironolactone is an anti-androgen, basically. It's a mineralocorticoid receptor antagonist. The mechanism through which it acts is it reduces your androgen levels. Basically, we use it for reducing your hair growth. Hair growth. Once the patient, if started with the hormonal pills for 6 months, if still the hair growth reduction is not there, only with the hormonal pills, then it is an add-on therapy for your hair problem. So basically, as it reduces the androgen levels, it will help in your hair growth. That is why your doctor must have suggested you for your excess hair growth. And the other thing, like if you're trying to plan a pregnancy, so in PCOS patients who are planning for pregnancy, we do not initiate spironolactone in such cases, because it can lead to fetal problems, fetal malformations. I hope I have answered I have answered this question clearly. Hello, Chand, am I clear?
Yeah, clear, doctor. Thank you.
Yes. Next question is, if pre-diabetic, is metformin necessary, or can I work out and try lifestyle changes and add checkup in 6 months? Yes, definitely. First, we go for the lifestyle modification. And even after 6 months, if your the glycemic, if your sugar levels remain high, and if you are not able to reduce your this PPBS, so for those cases, then we start with the metformin therapy along with the lifestyle modification. If the patient is motivated enough that he can go for the lifestyle and he will strictly follow this diet and exercise, so yes, for 6 months we can go for lifestyle changes and then consider the metformin as a second line.
There is one more question. Is it okay to have white rice, or does it spike the GI levels?
Yeah, it's a very common question. White rice, definitely, because it lacks fiber. It leads to rise in glucose values immediately. So if you see, I won't say that you have completely stop taking white rice, because if I say, you will stop it for a few months and then you will again land up eating huge amount of white rice. So I would say that portion control is important. If you are eating white rice, then eat around 40 to 50 grams, not more than that, uncooked white rice. 40 to 50 grams of uncooked white rice. Along with that, you can take one chapati, so that it will give you a balanced diet, and it will prevent the immediate spike in the GI levels. White rice definitely has got a higher glycemic index, so because it lacks fiber.
Okay. Thank you, guys. I think, is that all? Is there any other question? I think the time is also up. So thank you, doctor, for being so elaborate and explaining patiently and explaining all the questions. That is really helpful. Let me this session will be recorded, and I'll put it up. The link will be put up soon as well. So if you have any other questions or you want a consult with the doctor, please make sure that you can get it via UV Health app or website. Thank you so much, doctor. Thank you everyone for joining.
Thank you, Neha, for organizing this webinar beautifully. Thank you everyone for asking lovely questions and a very important clinical questions which we frequently face, like all over India, I'll say. And I hope for the good health for everyone. Okay, yeah, thank you.